join. We have a lineup of really stellar panelists and speakers tonight. For those of you that may be newer to the SVN, I'm Karen Bauer. I'm a nurse practitioner out of the University of Toledo Medical Center, currently shortly headed down south to Emory. I'm the current Society for Vascular Nursing president. We're really excited to offer this webinar tonight. We've been doing pretty much monthly webinars with a goal to really engage some new leaders, get some innovative topics out there, and give you all the opportunity to not only learn, but ask questions and network and get involved. So we're really excited to see you all here tonight. With that, I want to take the honor of introducing two of our speakers, and then I'm going to turn over to Dr. Mark Moline, who is at the Mayo Clinic in Rochester. We are extremely honored and lucky and excited to collaborate this evening's webinar with the American Vein and Lymphatic Society. For those of you that don't know, there is some time dedicated in March to lymphedema specifically, so we wanted to capitalize that and make sure that we give it the highlight that it needs. Also, we'll probably talk about tonight, the recent Lymphedema Treatment Act has really revolutionized the way that we're looking at lymphedema, a lot of paradigm shifts. So we wanted to make sure that we really pay attention and focus on some of those things. So without further ado, again, we have two really phenomenal panelists in addition to Dr. Moline tonight. So we have Lindsay Kwan. Lindsay is a nurse practitioner who graduated with her doctorate of nursing practice from Johns Hopkins University in 2020. She then joined Stanford's vascular surgery team in 2022 and currently is primarily working in their outpatient clinic. She does take care of a variety of vascular patients and specifically has interest in caring for patients with chronic leg swelling. So ton of interest and expertise coming from Lindsay. We also have Alex Harrow on today. Again, really lucky to have her. Alex is a registered nurse who graduated with bachelor's in nursing at North Dakota State University. Worked for about 2.5 years in North Dakota in the vascular surgery department there, and then also joined Stanford's vascular surgery team in 2023. So a really stellar duo here. She currently assists the vascular medicine and vascular surgeons in the outpatient clinic, primarily in a coordination role. So really, again, a broad range of experience here. And then Dr. Moline, I'll turn it over to you if you want to kind of introduce the AVLS. And then for you guys at the end of this, we will have some moderated chat. We want this to be open, want you to ask questions. If throughout the talk you have any questions, please put them in the chat. Don't be afraid, speak up, put your comments. And then at the end of the sessions, we'll have some roundtable discussion and moderated chat.
So first of all, Karen, I want to call you out for your excellent leadership. You've just been phenomenal for many years, and to be president of SVN is a big deal. So congratulations.
Thank you.
We just were so privileged to host you in Rochester 2 weeks ago, and you were sitting up on a panel, what we called WAVES, so the Wound and Vascular Endovascular Symposium and Skin Session. So we had you, Bill Ennis, who's down in University of Chicago, of course, as a vascular surgeon, Fuhad Suhaja, who's one of our critical limb ischemia specialists. Peter Klevitsky was moderating that session, Tom Rook, and then David Armstrong. So that was a really fun panel. And you guys covered a plethora of things in that. And I wish we could show everybody the strength of that panel, because ultimately, if you don't have a really solid vascular nurse with a great background who that whole session. And so again, thank you for participating in that, and thank you for your leadership and being present for that session with us. And
Well, I appreciate that. Great conference, and it's owed to people who paved the way, right?
Yeah, no, absolutely. It was really legacy sitting up there that day. So American Venous Lymphatic Society, AVLS. Now I want to change the paradigm on what AVLS stands for. It stands for artery, vein, lymphatic, skin. Right? Artery, vein, lymphatic, skin, instead of the American Society for Vascular or Lymphatic Society, because ultimately everything we do has to involve the whole triad if we're going to end up with having success in healing wounds. And I'm sure as Lindsay and Alex and I and Karen, you speak, we're going to really hit on dermal lymphatic functionality, getting edema out of the skin to maximize microvascular perfusion. There are so many things we can do to heal wounds in an accelerated, more cost-efficient way. A lot of that centers around, appropriately diagnosing lymphatic dysfunction, lymphedema. Of course, every venous leg ulcer we deal with has lymphedema, so-called phlebolymphodema, even though there's not an ICD-10 code for it. So, and as I was going through clinic today, and it's another one of those days where without excellence in nursing, because the education component, the really compassionate cares, the connecting, so much that happens the minute I leave the room. So I just want to applaud all of the vascular nurses across the nation and what they accomplish both in vascular medicine, vascular surgery, and in our wound clinics, because we can't heal patients on our own. And this is such a synergistic relationship to have, but we have to grow it. One of the things we were talking about was I'm a member of the Society for Vascular Surgery. Joanna was saying there's 6,000 members. Now, not all of them are practicing, but let's just call it 4,000 practicing SVS members. If you got a right hand and a left hand as a surgeon, which most people do, you need a right hand nurse and a left hand nurse, which means that the Society for Vascular Nursing should be about 12,000 strong across this nation, if not eight to 12,000 strong. So I certainly want to encourage people that are attending tonight to reach out to, find a colleague, join SVN, become a supporting member. And I think it really has to grow, because the stronger SVN becomes, the stronger SVS becomes, the stronger the American College of Surgery becomes. And if you look at the history of the Mayo Clinic, this clinic was built on a synergistic relationship between surgeons and committed people. Now, they were nuns at that point, but these were the people that were committed to improving patient care. The clinic doesn't exist without that symbiotic relationship, and it's definitely a two-way street. So again, I just want to applaud each of you for what you guys are doing at your institutions and for everything it took just to get to this point. And with that, I think, Karen, we're going to pass it on to Lindsay.
Yes. All right, I'm going to share my screen here. All right. Hi, everyone. I'm Lindsay. Thank you, Karen, for that lovely introduction. I'm going to be talking about the APPs and our role in navigating patients through their lymphedema diagnosis. I have no disclosures. I'd like to first talk about the APP's role when it comes to supporting the clinic and seeing patients with lymphedema. We're able to free up the physician's schedules and increase access for the patients. And in doing that, we're able to start treatment sooner and also provide more frequent interval visits for close follow-up, especially for those patients that need the weekly UNA boot wrapping or those weekly wound checks. And we're also able to collaborate with a variety of specialists. I've referred patients to interventional radiology, wound care centers, and infectious disease. And lastly, we play a key role in navigating the patient's experience through lymphedema, and that is the topic of today's presentation. So I'd like you to consider the unique patient experience for these patients who are diagnosed with lymphedema. I want you to start thinking about how lymphedema affects the patient in all these, in this list right here. Emotions. Think about how the diagnosis affects their emotions. Is it difficult for them to accept? Can it contribute to the patient's underlying anxiety and depression? It's important to consider their mental health along this journey. And what about their home life, mobility, ADLs? The physical limitations from lymphedema can make it really difficult for them to carry out their daily activities that perhaps was super easy for them to do before lymphedema. Some patients with lymphedema are caretakers for their spouse or another family member, and the physical limitation from lymphedema can make their job as a caretaker that much harder. And I've even had patients tell me a simple act is just getting out of a car can be difficult. And then consider comfort. There can be a lot of discomfort that goes along with the significant limb swelling and skin tightening. So it's important to acknowledge the patient's discomfort and not just brush it off. And what about their social life and their self-confidence? Does lymphedema affect the patient's ability to attend social events and socialize with friends and family, like before their diagnosis? And because of their physical limitation or because of how they look now. For example, I've had patients tell me that they can't wear certain clothing anymore because it'll reveal their affected limb. And lastly, we can't forget the expenses and time that's affected, because lymphedema treatment can be very costly and it can be very time consuming, especially if they have to order these expensive pumps. They have to dedicate time to using these lymphedema pumps and attending lymphatic massage therapy sessions, and then going home and having to do it themselves too. So a lot to consider, but I'd like to share with you 3 different patient experiences. These are 3 of my patients. They're all around the same age, but all of their stories are very different. So we have patient number 1. She is an 83-year-old female who presented with bilateral lower extremity swelling. And I have her past medical history here: hypertension, AFib, and she had a history of perforated colon. When she came to our clinic, we did a venous reflux study, and it showed moderate bilateral GSV insufficiency and minimal deep venous insufficiency. So she was offered radiofrequency ablation of bilateral GSV with stab phlebectomy. Unfortunately, this was all complicated by a hematoma that had formed beneath one of the stab phlebectomy incisions, and this required very, very painful in-clinic evacuation. And it was a very deep wound, and that had to heal by secondary intention. And during this time, we also noticed that with the tumescent injection sites, she was just leaking serous fluid nonstop. So she had this persistent edema despite the ablation. Her physical exam was also consistent with lymphedema. So it was, then we had decided that she had mixed venous insufficiency and lymphedema. So we started her on lymphedema treatment that I'm sure all of you are familiar with. We did the Uniboot, we did compression stockings, lymphatic massage, we ordered her lymphedema pumps, and we also referred her to our local advanced wound care center for assistance with healing that hematoma site. And her main challenge during this whole time was the emotional trauma and anxiety that she had. It started with being traumatized by that hematoma and the significant pain that it caused her. So then it became very frustrating for her to realize that the ablation didn't solve all of her problems, and it took her some time to accept that she had lymphedema. But thankfully, she had has a very supportive and attentive spouse who has continued to support her through her entire journey. And today, I just saw that she last week was discharged from the wound care center. She has no new blisters or wounds, and she'll just continue all of her therapies. And here I just have some pictures to show you. July 2024 is when she came to us. And in October, this is after the ablation, you could see that significant swelling in that left leg. In November, she developed some very large and painful blisters over both of her legs. And the most recent photo we have that she submitted in February, you could still see she has some swelling, but much improved from prior. And we applaud her for her efforts as she continues with her treatment. Now we have patient number 2. She is a 79-year-old female who presented with unilateral leg swelling, past medical history of hypertension, hyperlipidemia, CAD, rheumatoid arthritis, and chronic back pain. Before she came to our clinic, she was treated for cellulitis with no improvement. She went to urgent care in the emergency department and had a venous duplex done twice, negative for DVT. And then someone started her on Lasix and still no improvement. So this is a patient who has undergone multiple treatments and is clearly frustrated by the time she got to our clinic. We did a venous reflux testing and it showed mild, deep, and minimal superficial venous insufficiency. So no ablation was recommended for her. Her physical exam, as you can see from the photo, she had pitting edema from the left lower extremity all the way up to her left lower quadrant of her abdomen. So I discussed her case with one of our vascular medicine attendings, and she recommended a CT venogram of the abdomen and pelvis. And the patient was amenable to this, and results showed small caliber left femoral vein. And with this, I referred her to our interventional radiology colleagues who work a lot with veins, and they offered a venoplasty of the left femoral and popliteal veins. The patient had really high hopes that this would resolve her swelling, but unfortunately had no improvement. So this is when we initiated lymphedema treatment for her. Unfortunately, during this time, she developed cellulitis and she had multiple weeping wounds, and we had to stop our Una boot wrapping. We took a culture from her wounds and it grew Pasteurella. So I referred her to our infectious disease colleagues, and they determined that this was likely oral flora from her pet dog. So there was a lot of patient education in that realm for preventing future infections. But fortunately, she improved with antibiotics and we were able to resume our weekly wrapping. And finally, she was approved for lymphedema pumps. For her challenges during this time, she unfortunately fell and broke her wrist. So it was difficult for her to put her compression stockings on. It was even difficult for her to use her lymphedema pumps. And in addition, she is the sole caretaker of her husband who was in and out of the hospital. So she put her own treatments in the back burner for quite some time. And even now, she's only able to use her pumps once a day. But today, her leg is still pretty swollen, but the skin is much healthier with her treatments and her abdominal swelling is resolved. And lastly, we have patient number 3. She is an 82-year-old female. She first presented to our clinic in 2020 with chronic bilateral leg swelling. Her past medical history includes chronic hepatitis B, hypertension, hyperlipidemia, and TIA. When she had her study done, there was no left lower extremity venous insufficiency and only focal deep and focal superficial venous insufficiency in the right leg. So she didn't undergo any procedures with us. On physical exam, she had more pitting edema in the left leg and she had bilateral leg skin tightening. And somehow she was lost to follow up, but reestablished care in 2023 when we started her on lymphedema treatment. She is one of my favorite patients, such a unique character who came to clinic prepared, having read books on lymphedema, lipedema. She sought second opinions even down in LA, and just very committed to improving her quality of life, because for her, her goal was to not let her diagnosis of lymphedema affect her quality of life and things that she enjoyed. So today, her edema is very well controlled. I just saw her last week. She uses compression stockings, lymphedema pumps, and she still sees a lymphatic massage therapist. And most importantly, she continues traveling the world on cruise ships where she teaches bridge, which I think she's somewhere international now on like a 15-day cruise. So super happy for her. And this is just such a rewarding patient to take care of. So my take-home points: in vascular surgery, it's very easy for us to, as APPs, to focus on venous insufficiency as the cause for leg swelling. I'd like you to consider lymphedema as a differential. And the lymphedema diagnosis does not just affect the physical health. As you can see from my examples, it can affect the mental, emotional, and spiritual health of the individual. And each patient experience is unique, from the initial therapy to the challenges to their progression. There are successes, there are setbacks, and it can be a very long journey. But they have you to guide them along the way. And sometimes it can feel discouraging, but I have found that celebrating the little wins with the patient goes a very, very long way, and it can be very encouraging to the patient. So just know that you can make a difference in their life. Thank you. And I'm going to turn it over to Alex, who will be able to share the nursing side.
So Lindsay, can I ask a question during the transition?
Yeah, sure.
Really fabulous presentation. One of the things also is just the commonality of this in clinics, correct?
Mm-hmm.
I mean, it wasn't hard to find 3 cases to present for tonight. These patients we see a lot of them.
Yes. Yeah.
So how we're in an era where we don't have great diagnostics for lymphedema, and establishing a diagnosis is just critical.
Mm-hmm.
Can you walk us a little bit through how do you make the diagnosis of lymphedema?
A really good question. So for us, when we see a patient with chronic leg swelling or just leg swelling in general, we start off with a venous reflex testing just because we're in vascular surgery. We're thinking if we see something that we can treat with ablation or vein stripping, we will do that if appropriate. And then it becomes, okay, well, if they don't really have that much axial reflux or deep venous insufficiency, then for me, lymphedema comes up as a diagnosis. Then for me, I concentrate on the physical exam. For that one patient who had significant swelling, she had some abdominal surgery. So I'm thinking maybe there's some lymphatic disruption. And most importantly, I consult with our vascular medicine attendings and kind of get their idea on things. And that one patient, we ordered that CT venogram thinking maybe there was some more proximal reflux, and there wasn't. So that's when we said, okay, could be lymphedema.
And I'm seeing some of these patients now in our wound clinic because we're trying to get to the point where we have actually a lymphatic center. So we're working on that process. One of the low-hanging fruits to look at, because as we differentiate lymphatic dysfunction from true lymphedema, which I think there's a lot more lymphedema than we actually realize. Diagnostics are kind of difficult. But one low-hanging fruit to look at is the medication list. Because there are angioedema-causing medications that will make swelling worse and more difficult to heal wounds. One of the most common, Karen, is this a CME event?
It is not.
Okay,
This-
so I'm going to treat it like a CME event, but so
but
like
you
a
can-
medication like amlodipine, right, contributes significantly to lower extremity edema as an angioedema medication. So make sure low-hanging fruit, look at the medications, work on getting them onto another medication for blood pressure. High dose Neurontin can do the same thing, as can minoxidil. So looking at some of those types of medications can make your jobs a lot easier in terms of management. And then, of course, I need to call out Dr. Stanley Roxon, who's out at Stanford, right? Because he wrote a 2014 paper with Peter Morneber that really changed my whole understanding of the importance of lymphatics and the shifting of the classic Starling curve to the revised Starling curve that we know now because of this thing called the glycocalyx, which is a whole different conversation. But when you look at, and this is part of the talk I gave over noon hour for grand rounds and PM&R, when you look at the glycocalyx, because that's inside the 60,000 miles of your vasculature, arteries, veins, lymphatics, as the fluid comes out, we've all been taught 90% goes back into the veins. And that's absolutely not true. 90% actually has to go into the lymphatics. So if 90% of that fluid goes in the lymphatics, and that lymphatic fluid has to get from your ankle up to your left subclavian vein, the lymphatics all of a sudden take a prime importance in terms of management, all the way from compression to automated manual lymphatic devices and pumps. Like, we'll talk later on about some of the great ambassadors we have in ABLS, from the lymphedema pump companies to the compression companies that help lead the way in education, but also in working with the Lymphedema Treatment Act. So that shift that happened in the late 1990s, about the 100th anniversary of Ernst Darling's publication in 1896, that all of a sudden, if you look in PubMed at lymphedema publications, there's a sharp spike. So it's almost like a lymphedema renaissance started in the late 1900s or late 1990s. And we're all the benefactors of all these people doing benchtop to clinical bedside. And you presented three, again, very common cases: accuracy in diagnosis, phenomenal management. And that's the message we need to get out to all Society of Vascular Nursing, because the nurses are like the eyes and the ears. I think surgeons just fail to see this. And I think they fail to see it because we're not taught about it in medical school. And I think it's an interest. You guys have a phenomenal passion and interest in managing this because you see the joy it brings to the patient. So again, I just want to congratulate you on three great cases. And I know you could probably multiply that times 100 for what you're accomplishing in your clinic. And you're really having a huge impact on your community.
Thank you.
Thanks, Lindsay. I can start with my portion unless there's any other questions or comments we want to go through. Let's see. Hopefully you can see that okay. So thanks, Lindsay, so much for going through your portion of it. I'm going to talk more about the nursing aspect, and once the lymphedema is diagnosed, what we do to help obtain resources for patients to hopefully help reduce further exacerbations of swelling. So I'm going to go through the three main components of lymphedema care: the lymphedema garments, pumps, and lymphatic massage. So first, I kind of want to just highlight the Lymphedema Treatment Act. As you already mentioned, Dr. Moline, there's been several benefits of this for patients specifically with Medicare. More people are able to get lymphatic garments to be successful. I've had really great luck in ordering the garments through one of our DME vendors. They make the process really easy for us nurses, and then they reach out to the patients directly and actually mail the garments to them at home. And then the use of the coverage of multiple garments has been really instrumental in giving the patient multiple components, so one can be laundered or cleaned while the other one's drying so that they can use the other set. And then the change in limb size is instrumental as well. We know that sometimes there can be changes with weight, or maybe there's flare-ups with swelling. We still want to make sure that they have their lymphedema garments. So this Lymphedema Treatment Act has been really great with patients with lymphedema. First, I'm going to talk about the lymphedema garments. As we know, compression is a really big key factor to help patients manage symptoms. So when the patients come into our clinic, as Lindsay kind of already highlighted, we determine, do they have adequate compression at home? Sometimes they do have some compression, but most of the time it's not adequate enough to help manage their symptoms. So we will determine if they need multi-layer compression, as Lindsay highlighted in several of our cases. It may include 2-layer or 4-layer compression, and we'll determine on that based on the patient's level of edema, if they've had multi-layer wraps before, if they're having pain. If they haven't used the multi-layer wraps before, sometimes we'll have them check in a few days later with our clinic, have them come in, see how did it go? Did they stay up? Were they able to tolerate them? Otherwise, if they have used them, then typically we'll follow up in about a week and see if they need additional wrapping. Once we've controlled the edema, then we will order compression garments for the patient to wear based on measurements that we get in the clinic. And then we do have a compression cart you can see that we have in our clinic. And this is a great option for patients to be able to test different fabrics, test different types of compression garments like socks. And we have a variety of Velcro style wraps. We have an inflatable type of compression garment. And then we kind of look at what kind of compression they need based on their needs. So we really like the Velcro wraps for those who have mobility issues like arthritis, making it difficult to manipulate the socks. We do have, which have some under socks. Oh, sorry, we do have the Velcro wraps that have the under socks. So this, I have an example here, has that under sock that makes it easier for it to stay up for the patient. And as I mentioned, we also work with a company that creates an inflatable garment. So I did have that with me too, where they just pump it up kind of like a blood pressure cuff, and it makes it so it can stay on the leg a little bit better. This we usually use for patients who have more bottleneck swelling. And then finally, we do have some compression lymphatic pumps that offer static and pneumatic compression to help, again, milk or move that fluid from the distal aspect to more proximal. These devices are for those who are more ambulatory that don't want to be bogged down by the traditional lymphatic pump that we see where patients are sitting and elevating their legs. So the lymphatic pumps are typically used for an hour, once to twice a day. There's pretty strict diagnostic criteria to get it approved by the insurance. So that includes the diagnosis and location of lymphedema, the lymphedema stage and observations that must include at least 3 that I listed on the slide here, which are pretty easy to obtain based on the patients that we see. And then the conservative treatment start date, it does have to be documented in a provider's note specifically when they started the compression. It's not enough to just tell the insurance that they started it 4 weeks before the visit with us, which leads me into the 4 weeks of conservative management that are included for the lymphedema pumps. Medicare typically requires 4 weeks of the conservative management, including documenting compression, limb elevation, complete decongestive therapy, manual lymphatic drainage massage, and diet modifications. If they have commercial insurance, we can typically start the process so that they can get the pumps. And then we have heard from our reps that for Medicare patients, we can start the process. And once we get a 4-week follow-up measurement, that we can then submit that so that it expedites it a little bit for them. And then patients typically will start with what's called a basic pump that usually goes up to their thighs. Due to the movement of fluid, however, it can often get stuck in their groin or thigh area, making it uncomfortable for patients. So we do like to bump them up to the full pump that includes an abdominal component. However, also insurance has some barriers to that. They do need to show that they use the pump for at least 4 weeks, with the exception of cancer, where they can go straight to the full pump. And then finally, measurements. We always obtain ankle, calf, thigh, and inseam measurements for the basic pump. And because they're in the clinic, we'll typically get the hip and waist measurements as well, because we know that they'll likely go to the full pump later. And again, as I mentioned, we'll need 2 sets of measurements at least 4 weeks apart. Moving on to our third component of lymphatic massage, our certified lymphedema therapists are phenomenal. We work collaboratively with them and with the patient to make sure that they're getting the resources that they need. They will help provide manual lymphatic drainage massage. They'll teach the patient how to do it at home. And they can also help us to help the patient, bump the patient up from the basic pump to the full pump to, again, include that abdomen portion. I've included some websites that you can search for certified lymphedema therapists in your area, or those who have manual lymphatic drainage massage experience. And I found all of these on the Lymphatic Education and Research Network. And Lindsay kind of talked about the challenges already. I just really want to highlight them also, because I think it is so important to help with patient adherence and to make sure that we're getting patients the resources they need. So again, one of the challenges we see is the Medicare criteria. It's really difficult because they do need the 4 weeks of conservative management. How can we manage it in the meantime? So they can't get their lymphatic pumps. We're probably waiting for the patient to get their compression stockings if they don't have them already, or they didn't purchase them in the clinic. So that's where the multi-layer wraps come in, again, where we may be seeing several weeks in a row to help get the compression or get the edema under control. And then repeat measurements after 4 weeks. We have a lot of patients in California that live several hundred miles away. So that initial visit will get measurements, but we've been trying to find more creative ways to be able to get that second set of measurements at the 4-week mark. And then finding certified lymphedema therapists in network. This isn't something I thought I would have an issue with, but I had a patient recently who was having a really hard time with her insurance trying to find a certified lymphedema therapist that was in network. So I did mention to the patient to call her insurance, find somebody who's in network. She did, and then that facility required I send an insurance authorization. Unfortunately, the insurance only covered a 15-minute visit. So I ended up having a really great conversation with that therapist to figure out what additional supplies we were needing, where we were at with the lymphatic pumps, and working with their insurance department to make sure that this patient was getting all the resources she needed and approved by the insurance. Which leads me to my next topic of insurance in general can be difficult to work with, hard to navigate for both patients and the clinic. So we do our best to really make sure we're following up with these patients to make sure that they are getting the resources they need, or if they need to contact their insurance to find in-network DME companies. And then the last few things, again, Lindsay mentioned these as well, but patient adherence, it's really hard for some patients. They have limited self-care. Maybe they don't have as much support. So we might reach out to home health or the lymphatic therapist to help engage patients in their care. We may include family, whatever we can do, and really educating the patient and being there with them is really important. And then cost, understanding that these garments are not cheap. They can range anywhere from $50 for basic compression to over $300 or more for Velcro compression with a reduction kit. So trying to find ways, again, to help reduce those costs is really, really important to make sure that patients can adhere to what we're recommending. And then finally, the tips, tricks, and additional resources, if you will. To bypass that 4-week follow-up for those who live far away, we've been utilizing local lymphedema therapists, patients, families, and kind of and home health to get repeat measurements for us if they live far away. And then we do keep an eye on to see, like, do they seem accurate based on what they've had before? Again, just to meet patients where they're at since they live so far away. And then home health can also help us with repeat multi-layer wraps if they're unable to come into the clinic, but they need to be at home. Home health has been useful in doing that for us as well. And then even though Medicare requires waiting 4 weeks, again, we'll still start the process so we can expedite it for the patient once they are eligible to get the pumps. And then we work closely with our device reps to see if there's been any changes with insurance, any changes that we need to make to the documentation to ensure that it will be covered by the insurance so that the patient can get them. And then we've also been using LDEX scores in our clinic, which is a means to assess the fluid accumulation in the limbs. So it's been a great tool for us to better quantify the data. So versus measuring the patient's legs, which may vary per person. And then we also utilize photos, which Lindsay mentioned, which is a really great tool because you can show the patient the success they've had. Because I think sometimes when you're in it, they don't really notice or see and they can get disheartened. So the pictures also have been really great for us to show, like, this is where you came from, this is where you are. Same with the LDEX score. This is where you were and this is where you are now, and you're really doing great and you're showing great improvement. And then last few things, I found some really great resources on the Lymphatic Education and Research Network. And then the garment program I just found not too long ago on the National Lymphedema Network, where the NLN clinicians and organization members can refer patients who have financial hardships to get lymphedema garments so that they're paid for. So again, for those who are having difficulty paying for the garments. But overall, I just we as nurses and us as a team at Stanford, we really want to make sure we're connecting patients to these resources because we're only seeing a small snippet of their lives. So whatever we can do to make them successful at home is really what we want to work towards. And then my references. Thank you.
Alex, that was fabulous. So, couple comments. Would you let Dr. Fukaya know I'm going to put an application in to work with you guys?
Yeah.
I look at what your clinic is accomplishing. It's incredible. And Karen, you need to like take this model and implant this across the United States in vascular surgery clinics and in vascular medicine clinics and in wound clinics. I mean, to be doing LDEC scores is phenomenal. I congratulate you guys. I also have, now I've got envy. I've got compression cart envy. I saw that cart and I'm going, that's beautiful. I mean, what a great way to educate patients to have it physically so they can touch it, feel it, smell it, and understand what they're, what they're signing up for. I walk around with one of my hook compression garments and show it to patients and a Velcro garment, but you guys have really taken it to the next level and having that set up. So question, how do you take that model and like scale that to other practices? Because really what you just laid out, both of you laid out, is really a model. And I'm gonna say we need to get that in other people's clinics because that would improve outcomes dramatically.
Yeah, I think it's a great model. I think I've learned so much being able to compare when I worked in vascular surgery in North Dakota, how the process was there to what is out here. I do have to have a huge shout out to Lindsay, Dr. Fukaya, and actually my coworker, Judy Lau. She's one of the nurses. They kind of have started all of this and developed it to be what it is. But I think education is a big key component. And I think any chance we can get and getting the word out there to be able to show. We'll be at the conference this summer at SVN talking about this again and kind of the model that we've been doing because we are passionate about how important it is because so many patients suffer with it and sometimes for a long time not realizing what it is. So
Yeah.
I think whatever we can do to get the word out, and I have contacts in North Dakota too that I'm mentioning these things too, and the networking aspect I think is so important too.
Alex, tell us where Society for Vascular Nursing meeting is this summer and when is it?
New Orleans, June 4th and 5th, I believe, if I got the dates right.
And in conjunction with Society for
SAM.
Vascular Surgery again, correct?
Yes. Yep.
Yes. So in New Orleans is always a great town to visit, right? I mean, there's a lot of activities going on there. Are you at that session? Are you guys speaking? Is there a session about lymphedema during the upcoming SVN meeting?
Yes, it is. I apologize. I think we're June 4th in the morning at 8
Okay.
a.m. Talking about the collaborative approach that we have made. So similar to kind of what we're talking about today, but the collaborative approach and utilizing the APPs to get patients into the clinic sooner, because we were finding that if we were waiting for the doctor, their visits do fill up quite quickly. And so they were booking 3, 4, 5 months out. So utilizing the APPs has been really instrumental in kind of getting these patients in right away so we can prevent further emergency room visits or further, distress from the patient because it is really traumatizing. So, yeah.
And you bring up such an important point, access.
Mm-hmm.
And the thing we talk about in our clinic is we want this to run like a cancer clinic.
Mm-hmm.
We want easy access. We want the correct diagnosis. We want accelerated cares along the right pathways, and we want to decrease the recidivism rate because nobody wants their wounds back. Nobody wants cancer back. So you guys are really hitting on all those metrics of improving access, which ideally helps upstream treatment. And the sooner you pick up on it, the better the outcome should be. You've got a really great educational component. You're using all the tools from compression garments to your certified lymphedema therapist when available, to the automated lymphedema pumps, ideally in conjunction with CLTs, depending on what's going on. And you're really hitting on it all. Are you guys doing, oh, let me hit one more thing on research, because I just want to say that we need to take a Alex and a Lindsay and have you hired at all the big insurance companies in the United States. Because, and I just want to give our insurance companies, because I think we love to speak negative of them, and I think this is actually a great opportunity to hold their hands and say, nobody in your insurance company has been educated on lymphedema. We expect you to know nothing. We do have that background. Let us work hand in hand with you to educate your staff, educate your physicians on lymphedema, because once you guys understand it, now you're going to see where the cost benefit ratio is to providing good lymphedema cares up front. And I think we've actually seen this in the Lymphedema Treatment Act. And there was a lot of work on the American Venous Lymphatic Society, and again, our ambassadors in the industry, to put together meetings with CMS to present these kind of things. So, but we need educated folks like you actually working hand in hand with the insurance companies. Let's look at it as an insurance or as an educational deficit that's causing the problem, and hopefully not so much of the just pure denial aspect that I think we all want to go towards.
I think too, as you say that, Dr. Moline, I don't know how many of you are familiar, or Alex and Lindsay, I would love to get both of you involved with the Alliance for Wound Care Stakeholders, which obviously is wound focused, right? But they had a lot to do with the orchestration of the Lymphedema Treatment Act and do a lot with policy and advocacy. So as we're talking about insurance companies, you know, oftentimes as clinicians, we feel like we don't really have a voice, especially as nurses and APPs. We're like, well, what am I going to do, right? But that's been a really good avenue for us to use our voices, and for experts like the two of you to be able to lend your expertise on that scale. So for those of you that are on tonight too, it's something to look into if you have any interest with regard to advocating for policy at that level.
Yeah, and it's scalable, right, Karen? Because it does sometimes take some extra time. Sometimes you got to make a phone call. You got to be willing to serve. But I do think in the next 10 years, there's going to be a significant change in, especially we've all seen what's going on in wound care, right? I mean, they're compressing the tools. We're going to see this potentially come on April 13th, unless there's another delay in application with the camps. Management of lymphedema and all these folks actually can improve cost effectiveness of everything we do, from diabetic foot ulcers, who all have lymphedema of some component, to venous leg ulcers, even the pyoderma gangrenosum, and those inflammatory things all have dermal lymphatic dysfunction. So we can apply these principles to almost all these patients in our wound clinics and accelerate outcomes.
Yeah, for sure. We have a question that you guys kind of touched on, but I want to make sure we get it, that is in the Q&A. And I think, Alex, you did a really good job talking about the coordination and how you reach the patients. We really do have to meet them where they are. So the question is, what do you recommend when patients do have a long wait time? So Dr. Moline mentioned access, right? And how as APPs and nurses, we can improve that. What are some of the tactics that you use, one, to get patients in quickly, and two, when you can't, what are you doing in the interim?
Yeah, again, the APPs have been instrumental to that. I think a lot of these referrals do go to Dr. Fukaya and our vascular medicine team. Again, we're usually initially seeing them for venous insufficiency, but if they do think there is a lymphedema component, then a lot of them are going to Dr. Fukaya. And she, because she has such a great collaborative approach, has involved Lindsay, Judy, and I into these conversations to make sure, like, what is your next availability, Lindsay? You know, can you see this patient on this day? And in the interim, I would say if you're in a clinic where it is several months out, I think what I did too, something at Stanford, was put out a webinar of things that people can do in the interim. I think reaching out to primary care is a really good tool to start with, because that's frequently where they're coming from. So putting the tools in their hands as well to know what is available. Maybe they can't do all of it. I think the lymphedema, the pumps are difficult to kind of navigate around, but we can start with compression and we can go from there. And I think having somebody who's forward thinking of, let's at least get them into compression, is important. You have something to add, Lindsay?
Yeah, and just something quick on a very practical note, I wanted to bring up how you and Judy have put together that epic SMART phrase for those lymphedema pumps, putting down the whole checklist, and it makes it easy for us to just say, oh yeah, these are the morphology and symptoms, and oh, this is the start date. It makes it really easy for us to just throw that in the note, and then in turn easy for you to send over to the insurance companies and device reps to get things going. So instead of having to type everything out, just having a SMART phrase for that is very useful.
So Karen, can I bring up a caveat about when Monica Glivitsky and I presented at SVN a couple of years ago? So when I'm out visiting my kids in Mountain View and we're walking around the Stanford and Mountain View area, there are people with citrus plants in their front yards. I mean, literally like growing lemons and oranges in their front yards. Now in Minnesota, we grow pine cones, which is a different kind of flavonoid. But, you know, from the rinds of oranges, there's this medicine that's been used in Europe 50 plus years called diosmin hesperidin. It's a bioflavonoid. We just actually got that adopted. It's being sold in our DME store now. I had to give like 20 plus papers. 10 randomized controlled studies from Europe, one meta-analysis 2018 that looks at this diosmin hesperidin, also known as a micronized purified flavonoid fraction. And so I would say, as innovative as your team is, and as we're all looking for adjunctive options for treating our patients, I think it's important to pay attention to what some of the stuff that's happened in Europe and where they've done really, really good research. And we should leverage that type of research to improve our outcomes. So MPFF or diosmin hesperidin is one of those. You know, and people have talked about, I've seen studies from Europe on electrical stimulation therapy. We've seen with different forms of infrared lights, and we've seen even swimming, balneotherapy, because we all know if you stand in a pool at waist high or at shoulder high, that's equivalent to 30 to 40 millimeters of compression stocking on your legs. So water aerobics, things of these. And these are some other adjunctive therapies we can start to think about to give our patients a chance to get out into community and to be with others, and kind of gets into that blue zone type of living, like they talk about on Loma Linda, which again, I saw threads of that in both of your talks about how you're really working with patients, because a lot of our patients do have that mental health component, right, that you touched on. And you guys have both demonstrated very well how to help break down some of those barriers, which brings back some joy and some ability to thrive in their both in their families and the community. So again, I just want to compliment you both on excellent presentations and what you're accomplishing in your clinic.
Yeah, we really, really appreciate everyone tonight. If you don't see any other questions, I do have one. I guess I have two very quickly. I think we have like 6 minutes. I might have three. One of the things that we see a lot, especially in our patient population, is obesity. So as we talk about getting into like adiposity, and Dr. Moline, for you also, like with the manual lymph drainage, and as we're looking at pumps that go into the abdomen, how do you guys manage that with patients? And, you know, how much are you talking to them, and what kind of verbiage are you using to manage the obesity that oftentimes coincides with lymphedema?
Can I make a brief comment? We have to
Mhm.
differentiate lymphedema from lipedema also.
Lipedema, yeah.
Because
Yeah.
because you know, Karen Earps obviously has done a lot of work on that, Caroline Fife and that whole group. And if you make the wrong diagnosis, because the women will come in saying, I try to lose weight, I can lose it to my waist, I can't lose it below oftentimes. That first paper in the world came out of this institution in 1940 from Dr. Allen and Dr. Hines. And everybody knows how to do the Allen test, right? You all know how to do the Allen test if you're looking at radial ulnar. It's the same Dr. Allen that wrote the first paper on lipedema in 1940, and a follow-up paper in 51, follow-up paper in 52. So we have to make the right diagnosis, number one. Number two, oh my gosh, Karen, I got on a soapbox and now I lost my train of thought. You were talking about the lymphedema, correct? Oh my
And
gosh,
obesity, like what do you do?
obesity, thank you.
Yes,
So
yeah.
don't for those patients that have mixed, where they do have diabetes, we're sending a lot of those folks for GLP-1 agonist evaluations. And Steve Dean out of the Ohio State was the first one. I still remember 3 years ago when he told me about GLP-1 agonists. And now I'm sending several patients a week to be evaluated for GLP-1 agonist. Because if you can't get the BMI down, you're going to have a really hard time improving dermal lymphatic functionality in the lower extremities. It's pure hydrostatic indifference pressures and it's gravity, and you can't battle both. So we have to help them in that manner. It's not for everybody, but certainly should be thought of, I think, in 2025 as an option.
Yeah, I totally agree on the GLP-1 agonists. While not this patient had venous insufficiency and not lymphedema, but same applies. I sent a referral back to her PCP to consider one of those injections, and she was able to get on it. And next time I saw her in clinic, she felt so much better as a person and just more motivated to continue with her therapy.
Nice. Okay. I think second thing, two quick ones. One, this is probably more for you, Alex, but you too, Lindsay, the inflatable compression. I have some experience, but can you share with us your experience with that and patients' experience with that?
Yeah, I think again, we're using it more for bottleneck edema, which is usually lipedema, so not exactly related to lymphedema, but it is really great for that. When you have really skinny ankles, it can help with that. It does come with an undersock. I took these from the clinic. I will bring them back, but it has an undersock that comes with it that's supposed to help a little bit as far as the sensitivity of the skin. There is a component where it can go up into the thigh, but from what I've heard is because the inflatable is kind of like a plastic material, sometimes it can get a little uncomfortable. But I think the patients that have been using the lower component have been liking it okay. Again, it gives them a chance to kind of be up and mobile, because again, you have this portion that you can take this off and then it will still bend, so they don't have to like leave this dangling or whatever. But I would say it's probably mixed reviews. I don't know how much we have been using it for our patients. I think it's just specific instances. If we've tried other types of compression that maybe aren't working, that might be another option for them to use. And that's this one. And then there is another inflatable style where it's pneumatic and static compression together. I think that one has been pretty well received. That one I think is a little softer of a material.
Awesome, thank you. And then there's a question, probably use our last maybe 2 minutes, about nuclear medicine diagnosis. So I'm gonna botch the word as I always do, but the lymphoscintigram. How much are you using that? And Dr. Moline, I know that like you and I have talked about this. What is the overall impression of that, accessibility to that, insurance coverage of that, and how useful it is?
So we can order it. It comes down to matching physical examination to the study. So you have to know the limitations of the study. I just had somebody today who's clearly got lymphedema. He had a lymph node biopsied out of the left groin, clear collection there, and you can see a little bit of the ventral medial bundle up his left leg, but was read as normal. And when in fact he's, clinically got stage 2 lymphedema for sure. So there's another test that Eva Sevick and Caroline Fife and Melissa Aldridge down at University of Texas at Houston have done a lot of studies on publications, but it's not ready for prime time. It's called near infrared fluorescence imaging, microdosing indocyanine green into the dermis like a TB shot, and then you use a infrared camera that's much like a night vision goggle system, and you can actually watch lymphangion contractility. I was part of a team that published a paper on that just within the past year. In fact, I was one of the people that got injected 32 times with microdosing indocyanine green, and we did the mapping stuff. So, but that again is not ready for prime time. And then now there's magnetic resonance lymphangiography where you can inject with spinal needles into the groin indocyanine green and look at central lymphatic conducting disorders. So those I think Stanford does MRLs, San Francisco, University of Penn, our institution, that's another growing opportunity for diagnostics. But the peripheral, I'll tell you what, Karen, what we need, thermography. And could we ultimately, there's two papers that have been published right now, one in Poland on upper extremity post-mastectomy and one in Africa on filarial disease, where they use thermography and to help make the diagnosis of lymphedema. So ultimately, could we have a highly sensitive thermography device that can help pick up on lymphatics? It's probably going to take some AI pathways and enough pixels, but we need point of care, non-invasive diagnostics to help us, because I think we're missing the diagnosis in a lot of folks. And kind of like the Star Trek tricorder, right? Ultimately, we're going to have that kind of device in the next 10 years that can really help us accelerate diagnostics in these folks. Because if you can't see it, the vast majority of people are not diagnosing it. And unless we get an Alex and a Lindsay into everybody's clinic across the United States, a lot of people are going to continue to suffer and go undiagnosed and inappropriately treated. LASIK does not cure lymphedema because that's intravascular. That's not maximizing lymphatic functionality. It's got to be a different route, and we have to change some of these old dogmas that die hard, and really get into 2025 understanding of how to manage lymphedema.
Yeah, awesome. I love that. And that's a take home there too, with regard to the diuretics or Lasix and whatnot. All right, so we are out of time. Lindsay and Alex and Dr. Moline, thank you so much. Phenomenal talks, wonderful input. We're so lucky to have you. Thank you so much for your time and being here. For everyone on, you got the plug about the SVN conference in June in New Orleans. We have a wide breadth of topics. We have a ton of fun opportunities to network, to get involved. We're going to have these two amazing speakers back with us. So if you can join us for that, we would love it. If you had a question, there's a couple that just came in now. If you had a question that was put in the Q&A, Lindsay and Alex, if you're willing, we can forward those on to you guys. There's just a couple, but we can have Lindsay and Alex perhaps respond to you all to make sure that we get as many of those questions that are just coming in now answered for you. And with that, thank you guys so much. We thank AVLS. Dr. Moline, thank you so much for orchestrating this. We appreciate everyone being here tonight, and we hope to see y'all soon.
Thank you
Have a
so
great
much.
Thank you.
Thank you.
Good.